So let me debate if natural progesterone be offered routinely in MHT. When we started this debate, I thought that there would be something like this, Petra, but when I asked Irene with this always, polite approach, she said that she would prefer something like this. So these are my conflict of interest, mainly academic. How many of you believe that the best thing we can do as menopausal hormone therapy is to give estradiol, especially through the transdermal route, and then, as Petra said, micronized progesterone? This is the best. You have to always do this. How many of you believe this? The majority. I have a difficult job, but not all. Let me see if you will have the same approach in 15 minutes. This is the famous English poet, Rudyard Kipling. He said that I have 6 honest men serving me, and their names are where, what, when, why, how, and who. So let's use this and ask some of these adverbs. So what are they? Progesterone? As Petra said, progesterone is an endogenous steroid sex hormone. It has been involved not only in the menstrual cycle, but in pregnancy, embryogenesis, brain function, you name it. If you have a skeleton of 21 carbons, you have the progesterone. If you have only 19, you have testosterone. And if you get rid one of it and you have 18, you have estradiol. This is very educational figure. We used to know from the medical school that in the second part of the cycle, the luteal phase, we have an increase in progesterone. But the real pharmacologic figure is something like this. That means the variation of estradiol throughout the cycle is about 200%, whereas the variation of progesterone is 1200%. So it's a very important issue. Another important thing is that we have many progesterone receptors. We know the usual nuclear receptors, and we know there is also a non-genomic effect, a plasma membrane receptor for progesterone. But on top of these two, there are many other. There are progesterone receptor membrane component, glucocorticoid receptors, progesterone goes there as well, GABA receptor, and these are only the agonistic factor. There are cases that progestogens act as antagonists, and these are some cases of it. So it's a very complicated thing. Which are they? We usually use the word progestogens either for endogenous, natural production of progesterone and the metabolite, and we use the word progestins for the exogenous, for the synthetic one. So welcome to the brave new world of progesterone and the derivatives. This is the progesterone up there, and you have all these derivatives that produce normally. And it seems that the equilibrium between them is of importance. Now we have a lot of synthetic components, that is progestins. As you can see, we have 6 groups of progesterone derivatives, not 6 substances, but 6 groups actually. We have 5 groups of testosterone derivatives, still with progestogenic activity, and of course some derivative of spironolactone. Let's see them one by one. Petra discussed with you only about progesterone, so the natural product, and the dihydrogesterone, but look how many other we have. I have put in bold some of them because they are usually used in different medication for distant purposes. And I continue to present to you the progesterone derivatives. And let's go now to the testosterone derivatives, such as danazol, such as nandrolone, such as tibolone, of course, desogestrel, levonorgestrel, dienogest, you name it. And then we have the spironolactone, the most famous is, derivatives, the most famous is drospirenone. So it's a lot. What do they do? Of course, we discussed today their use in menopausal hormone therapy, but of course they are used for menstrual regulation as well, for pregnancy support, as their names sublimes, for contraception, you name it. For all these things we discussed today, that is the vasomotor symptoms, the genitourinary symptoms of the menopause, even the long-term complications, osteoporosis, cardiovascular disease, dementia, you need estrogens. The only reason you have to use a progestogen is endometrial hyperplasia, to avoid this. If this is not the case, as it is the case in hysterectomized women, there is no need to use such a component. Now let's go to the heart of our debate. What is their role in MHT? So should natural progesterone be offered routinely in MHT? You said yes, but what exactly means routinely? Does it mean regularly? Does it mean frequently? Does it mean without other consideration, or does it mean always? Well, I would use a preparation routinely if it was very effective, if it was very safe, and if it was very convenient. But I think that this is not the case with progesterone. If we give it in a continuous way, you would expect to result in amenorrhea. Am I right? But this is not the case. As you can see, after using it for about 1 year, 12 cycles, 13 cycles, you can see that only a little more than 50% of the women result in amenorrhea. So it seems that it's not very effective for the endometrium. It's not very convenient as well, because these are well-known symptoms of high progesterone. Breast swelling, water retention, fatigue, headache, peptic symptoms, you name it. And of course, we have the rare but very severe case of progestogen hypersensitivity, with a lot of disturbances from the skin, from the immune system. So it's not the safest thing in the world. What about breast cancer? I know that this is an advantageous area for progesterone, but I would try to debate this as well. It does not mean that progesterone is the best thing in the world. You can see from this study that if you have increased progesterone, to be precise, per 1 standard deviation increase in progesterone, the natural progesterone, the endogenous progesterone, you have a statistically significant increase in breast cancer. So what exactly do we do when we give exogenous progesterone? And how do we involve this, we dysregulate this equilibrium between all the other progesterone metabolites we discussed earlier? Things are even more complicated if you take women with low estrogen, so they are in the lower quantile of estrogens, then you can see that if the endogenous progesterone is increased, there's the risk for breast cancer, it's exactly that, is decreased. So it seems that if endogenous estrogen is low, then it's good to have increased progesterone. The overall risk for breast cancer is lower. This is not true if you have high endogenous estradiol. Then as far as you have more progesterone, then you increase the probability of having breast cancer. So it seems that it is a very complicated interaction between estradiol, progesterone, and their metabolites concerning breast cancer. And on top of this, there are much more effective risk factors for breast cancer, most dangerous risk factors for breast cancer, and here are some of them that were for sure more severe than the type of progesterone we use. But of course, it's not only breast cancer, it's endometrial cancer. There are many women that they have anyway a low risk for breast cancer, but may have an increased risk for endometrial cancer. As you can see, the risk factors for endometrial cancer are different. It's increased age, obesity, PCO, type 2 diabetes. Some of them are the same with breast cancer, but some of them it's not. Look at the appearance of the endometrium if you give progesterone. It seems that there is, and this is the appearance of an endometrium if you give levonorgestrel, usually with a intrauterine device. It's very clear that you have, if you have this, a pseudo decidualization with progesterone, but you have a complete decidualization with levonorgestrel. It seems that it's more effective, and probably this is the pathophysiological basis why it reduces the probability of endometrial cancer. Is things like this? It seems that it is, if you use from the famous French study that already Petra presented to you, if you use a combination of estrogen and micronized progesterone, you can see an increase in the hazard ratio of having endometrial cancer, and the same is true with dydrogesterone, but not with other progesterone derivatives. It seems that they are actually protective or almost protective for endometrial cancer because they are more effective concerning the endometrium. 10 years later than the previous study, the NICE summarized it, but still we have that study I presented you, that if you give a combination of MHT that contains micronized progesterone, you have an increased probability of endometrial cancer, but this is not the case with other progestogens that they are more protective. Gombel, in this review, put together the probability of having endometrial cancer using micronized progesterone. And you can see that if you want the best protection, you have to go up to 300 milligrams of micronized progesterone. And then in that study with the best protection, they gave conjugated estrogens. In all the other combination, you have a degree of non-responding, so subatrophy of the endometrium rather than the true atrophy, the decidualization we discussed. That's why Gombel concluded that progestogens, of course, protect the endometrium against the proliferative effects of estrogen, but whereas micronized progesterone is apparently safer for the breast, I have to admit it, it could be less efficient than synthetic progestins on the endometrium. That's why these are the best things that you have to do in order to protect the endometrium. Now, if in a very nice systematic literature review of micronized progesterone, these were the results, that oral micronized progesterone provides endometrial protection, but you have to use it sequentially for using 200 micrograms per day. The vaginal route, you have to give it once again sequentially, giving at least 100 milligram, but there is what you voted as the best approach, transdermal micronized progesterone does not provide endometrial protection. Do you know who wrote this review? It was Petra. And of course, he did the right way. This is the evidence. So how do we conclude? Should natural progesterone be offered routinely in MHT? I translate it as in all cases. I would say no. I believe that I have convinced you that it's not the most effective thing in the world. It's not the safest, and it's not the most convenient. I could easily say that, of course, the endometrium must be protective from the estrogens. We all agree to this. Progesterone, micronized progesterone, natural progesterone, may have benefits over other progestogens regarding breast cancer and venous thromboembolism. I have no problem to admit this as well. But other progestins are more protective on the endometrium than progesterone. So physicians can always must prescribe the right doses and the right duration. Actually, if you think it, why use only micronized progesterone and estradiol, transdermal, and not use tibolone that has certain advantages concerning the sexual function that we discussed? Why leave away the combination of estrogen with levonorgestrel, with excellent characteristics, very strong endometrial protection, excellent bleeding control, and it is contraceptive as well if this is the case? And why leave alone even the TSEC, the combination of estrogen with vasodoxifen that has other characteristics, so avoid the systemic progesterone, or even in the cases of progesterone intolerance that we discussed, you do not use a progesterone in this case, you use a SERM on top of this. So I think I have convinced you that it's not the only route to use this system, this combination, estradiol, transdermal, and micronized progesterone. You have to choose your weapon. The queen may be the most powerful piece in chess, but sometimes you can do the job with a rook, even with a simple, humble pawn. Thank you very much for your kind attention.